You read my mind. I was just going to ask you to start recording. Okay, well, we will get started, and then if people want to join, I'll just let them in. But we are very excited to welcome you to our April SOAR webinar. Today, we're going to be talking about best practices to decrease opioid use post-cesarean. So we have three different presenters today presenting on different kind of subject areas around this topic. And our first presenter is going to be Dr. Kenny John. So Dr. Kenny John is a third-year anesthesiology resident at Brown University and Rhode Island Hospital. And in July, Dr. John will be transitioning to a critical care fellowship at Beth Israel Deaconess in Boston, which is super exciting. Dr. John has previously worked on an ambulance as well as worked abroad in Senegal and Rwanda, focusing on critical care and anesthesiology. So please help me give a warm welcome to Dr. John.
Thank you so much for having me, guys. And thank you to Elena for reaching out to me and asking me to participate in this talk. So I'm going to share my screen and get going. I know we only have an hour here and I kind of have a lot of info to get through. Elena kind of told me this is on the informal side. So if you want me to slow down or stop at any point, feel free to just talk over me and I'll pause on the slide and we can talk about it more. Otherwise, I'll kind of just keep going so I don't cut into other people's time. All right, so I'm going to be talking about perinatal opioid prescribing practices. And learning objectives are going to be providing some background on current opioid epidemic, some of the OBGYN practices around postoperative opioid prescriptions, as well as the management of pregnant patients who have substance use disorder. And I have no financial disclosures. I will let you know that, like Elena said, I'm not trained in OBGYN, but I am trained in anesthesia, about to graduate in 2 months. But I work very closely with our OBGYN colleagues. In fact, we've been going over to our Women and Infants Hospital here in Providence, Rhode Island, quite frequently since we've been picking up more call there. So I've been seeing quite a few pregnant patients and post-cesarean section patients. Okay, so first, let's start with the basics of what opioids are. So there's really three broad categories here that's going to become very apparent as I get into more of the background of what opioids are. The first one, which is what this talk is really about, is prescription opioids. So those are opioids or medications that are prescribed by healthcare providers, usually to treat moderate to severe pain. So common examples are going to be your oxycodone, your hydrocodone, morphine, and methadone actually falls in this category as well. Fentanyl has gained a lot of publicity sort of recently in the last 5 to 10 years because that's becoming more of what you find on the streets. And that's what we consider a synthetic opioid. It's much more potent, and that's why people are overdosing much more, because the dosing that people are getting on the streets are at a deadly concentration. And they're used for more severe pain, commonly used in like cancer pain. And then heroin, obviously you've probably heard of heroin, illegal, highly addictive opioid drug, usually is injected, smoked, or snorted, and commonly seen in conjunction with other illicit substances. Okay, so the current state of the opioid epidemic, just minimize that there. So this graph kind of shows you the rise of just overdoses for any drugs. So from 1999 to 2021, you see a clear spike. So starting with 20,000 deaths from overdoses, now we've reached 6 figures of over 106,000. Most of these, like you'll see from the next couple of graphs, come from opioids. In 2020, in fact, 75% of these overdoses were from some type of opioid. So the most common, like I mentioned, is coming from synthetic opioids, which is fentanyl. And this graph here is kind of nice because you can see the different substances that have been causing these overdoses. So that top line that takes a sharp increase at 2015, that's going to be fentanyl. And then the things that fall under that are going to be your methamphetamines, cocaine, and then prescription opioids fall fourth on that list. Here is just a graph that shows you just opioids. So it's very similar to the overall drug overdoses, where there's that steady increase. And then over the past decade, there's a sharp rise in overdoses. And then this graph I think is quite interesting because this is just looking at prescription opioids. Now, when I was going through medical school and medical training, a lot of my attendings would tell me when they were going through training, they would have these reps from Purdue Pharmaceutical come into their sort of lunchtime and give them different talks about these new medications they have. They would be basically selling them on oxycodone or Oxycontin, saying that it wasn't addictive. It could be used for things outside of chronic pain, or excuse me, outside of acute pain, for things like chronic pain, chronic back pain. And that's where you start to see this rise of opioid use. And with that rise of opioid use, we start to see more and more overdoses because of that. And then the yellow line on these bar graphs represents fentanyl, which again, really spiked around 2015. This graph I really like because it comes back to those three different categories of opioids. So the first rise that we see is with the prescription opioids starting back in the 2000s. Heroin comes into play right around 2010, and then fentanyl comes into play right around that 2013 timeframe, and it's sort of taken over the most common reason why people overdose. So what's being done? It's a very big deal, and you hear about it a lot on the news, and that's because about 187 people are dying from opioid overdose every day. And so the CDC has really taken on this initiative to really put some focus on how they're going to prevent this and how they're going to provide surveillance for this. So they're monitoring trends, they're advancing research. There's, groups like you guys who are building awareness and creating a practice where we can somehow fight this from the healthcare system aspect to reduce how much opioids are going out into the public and reducing things like diversion and accidental overdoses. So coming back to prescription opioids, let's talk about that a little bit more. So like I mentioned, it's typically used to treat moderate and severe pain. And in our scenario, we're talking about post-surgical. So I think my next one actually is going to talk about how it's related to obstetrics. So C-sections are the most common inpatient surgical procedure in the US. Hysterectomies are not that far behind. And prescription opioids are really the mainstay of treatment for this post-operative pain control. Surveys have been showing that postpartum patients are actually prescribed more than what they require, and I'll get into some of those numbers in a little bit, but this leads to excess pills. And having those excess pills around the house in the community becomes a major source of misusing or diverting these opiates. And that's where a lot of these addictions and then overdoses can happen. There's been a growing interest in how providers can dispense the correct amount of opioids for acute indications like post-operatively, like post-C-section. So what is ACOG doing? ACOG, for those of you who don't know, but I assume most of you do know, is the American College of Obstetrics and Gynecologists. And this is a large panel of basically majority of practicing OBGYNs, about 90% of them, has about 58,000 members on them, that kind of guides the practice of OBGYN in this country. So they publish recommendations for all sorts of things, but since we're focusing on opioid use, for their recommendations regarding that, they really highly recommend that we're screening for non-medical use of prescription drugs, which I believe one of the later speakers is going to talk about screening methods. Also limiting the abuse and diversion and educating patients on the safe use, storage, and disposal of these medications. Now, some of these guidelines can differ from year to year. Every few years, they sort of refresh these guidelines and new ones come out. But some of the common recommendations that you'll see over and over again are tailoring these prescriptions to the individual patient. So I'll get to a study in a few minutes, but really figuring out how much does this individual patient in front of you need to take home with them to provide them the adequate pain control to recover appropriately. Providing the lowest dose and shortest amount of time, kind of echoing what I just said. And then again, counseling patients on the risks and the benefits of these prescriptions so that they know what they're getting into. For some of these patients, it might be the first time that they're taking opiates. And so it's our responsibility as a healthcare provider to explain the risks and the benefits and how to take care of themselves while they're on this medication. So one of the studies I'm going to talk about right now is this cross-sectional national survey, which basically looked at different ACOG fellows and junior fellows, which is sort of ACOG's terminology to talk about attendings and residents who are part of that organization, to describe their knowledge and their prescribing practices for opioids. Their sample size was, they sent out about 300 surveys and got about 179 back, which is a little bit lower than the average response rate for most surveys, but still quite a bit of data to work with here. And so the questions that they were primarily looking at were sort of demographics about the physician, how long they've been practicing for, where geographically in the country they're practicing, what some of their opioid prescribing patterns were, and their knowledge regarding the proper use and misuse of opioids. So this is one of the charts from that paper. And if we focus in on those first two lines, vaginal delivery versus cesarean delivery, so the number of OBGYNs is going to be that second column there. So 19 out of that 179, or 22% of providers, prescribe opioids after vaginal delivery. So not a lot, but probably more than I thought would have prescribed. And then after cesarean section, about 94% of providers prescribe opioids. And if you look at the number of pills right next to it in that column, 20 for vaginal delivery versus 30 for cesarean delivery. And then you can look kind of down the hysterectomy, abdominal versus laparoscopic, not too much of a difference there. I think the other interesting thing about this chart is if you look down at the endometriosis and the chronic pelvic pain, you don't have a lot of providers prescribing them, 24% for endometriosis, 18% for chronic pelvic pain. But if you look all the way to the right here, that column is talking about their comfortable level, their comfortableness with prescribing opiates. And only 68% of providers, when they're prescribing it for endometriosis, were comfortable doing that, and 41% for chronic pelvic pain. So even though providers are prescribing opiates for these reasons, just about half of them are really comfortable doing that, which I think is pretty eye-opening. This graph is really just representing that there's not too much of a difference regionality-wise, comparing the Northeast to the South, the Midwest, and the West in terms of how providers are prescribing opiates. And then this chart is talking about adherence to recommendations. So like I talked about before, performing an opioid dependence screen is one of the recommendations, providing the smallest amount of pills, tailoring opioid prescriptions, and counseling patients on the proper disposals. This chart shows that most providers are pretty good, or at least they say they're pretty good at providing the smallest amount of number of pills and tailoring the opioid prescriptions to their individual patients. Although if you look at the number of pills prescribed, even the people who say that they provide the smallest amount of pills is 27 compared to 30 who don't think they provide the smallest amount of pills. So it's really not that big of a difference there. And same thing for the tailored opioid prescription, 28 versus 27 pills. But the more interesting part here is that not a lot of providers are doing the opioid dependence screen. Only about 22% are doing the screening, and counseling on proper disposal, only about 17% are doing that, which again, I'll get into. This is really where we're seeing a lot of diversion happening when patients don't know how to dispose of their extra medications. This is just another example of OBGYN's knowledge and misconceptions about how opiates are used and abused in the community. So 56% of OBGYNs themselves knew how to dispose of opioids. I did a quick Google search just since I'm not from Denver or Colorado, just to see what was available for patients out there. And it seems like there's a ballpark overall, like around 100 different locations in the greater Denver area, which are mostly like pharmacies or police officers or offices where you can drop off your pills and basically dispose of it that way. And then the other interesting part was that OBGYNs most commonly thought that misused opioids were coming from prescriptions from multiple healthcare providers and not from the fact that they were getting overprescribed medications, which again, that's really the theme here, is that we want to tailor how much we're giving patients so there's not too much left over for there to be diversion or abuse. So that gets into this other study that I thought was very interesting out of Boston, where they did what's called a shared decision making. So this was done in 2017. They had about 50 patients where these patients were undergoing cesarean delivery, and they participated in a 10-minute discussion with either an obstetrician or an anesthesiologist. And what they basically talked about in that conversation was what you could expect when you're having a C-section in terms of pain and what the average number of pills were prescribed. So this link here will actually take you to their PowerPoint that they go through with patients, and I can put it in the chat once I'm done talking so you can look at it deeper. But just to give you some sort of highlights that you can look out for, they would say that on day 2, your average pain score post C-section is going to be about a 5.5 based on previous patients. And then they gave a number for 1 week after your cesarean section, and then for 2 weeks after your cesarean section. Then they also provided the patient with data about if a patient on average had a 7 out of 10 pain, they went home with 28 pills. Or if they had an average in-hospital pain scale of 5, they were going home with 23. So that was kind of informing the patient of what a normal amount of medication would be normal to bring home, and made it for a better educated decision. And as you'll see from these results, the average number that these hospitals said that they were prescribing prior to this decision making was 40. And this top number shows that they actually cut down those tablets to 20. So they were able to cut it down in half by doing this process. The number of oxycodone tablets that were used were actually still less than what was prescribed, about 15.5. And so it left about 4 tablets remaining on average. The need for refills here is kind of interesting. There was 4 patients who needed it, which is about 8%. And of those, 3 of them had complications regarding their surgery, which was going to have a higher baseline pain score. But what's even more interesting is that 90% of these patients said that they were either satisfied or very satisfied with their outpatient pain management. And I think that really just goes hand in hand with having the patient be taking ownership in that decision making, educating them in what the expectations are post-surgery in terms of what their pain is going to be, and then also educating them in what the risks and the benefits are for these pills when they take them. And the other interesting thing was about 2/3 of these patients had a disposal strategy for unused pills. So again, driving home that point of if you don't use these medications, then you should have a plan for how you should get rid of them. Okay, so the last thing I'm going to talk about here is opioid use disorder in pregnancy. Substance abuse really affects patients across all racial, ethnic, and socioeconomic groups. So it's something we should keep in mind every time we're talking to patients who we're going to be prescribing opioids to, just to make sure that we're not putting them in a dangerous situation. Patients who you do suspect have some sort of substance use disorder typically will benefit from some sort of multidisciplinary long-term follow-up. And this is both medical and social support. And things that are going to improve these patients' outcome are going to be early universal screening, which we're going to talk about later, a brief intervention, and this can even be just engaging them in conversation, providing some feedback and advice going forward, and then again, referral for treatment so that they're able to get that long-term follow-up and not fall into a relapse. So patients who come to you who have chronic pain, ideally you can try and have them do alternative pain therapies. This is typically exercise, physical therapy, behavioral approaches, as well as non-opioid medication. So that's like your Tylenol and your NSAIDs if it's safe for them to use. And then you also want to discuss the risks and the benefits, like I've been saying, of opioid use and review their treatment goals. So I think talking about the infant developing neonatal abstinence syndrome is also something that you can really touch the patient's heart with and really make them realize that, you're not just affecting yourself when you're making these decisions, but there's also, your child who's going to be seeing these medications as well. And so there's 2 of you who are at risk for having medical problems going forward. As a provider, you can use the prescription drug monitoring program. This is something that I've used multiple times throughout my residency and my career, just to see where patients are getting medications from, if they've gotten opioids in the past. It allows you to see different providers that have written them prescriptions, which states they've gotten prescriptions from, and the dates, so that you can see how frequently they're getting these medications. And this is also a good opportunity as a healthcare provider to provide treatment in an often marginalized community and avoid any criminal action to really avoid institutionalizing these patients and setting them up for what I think would be failure in the long term. So the biggest treatment that we do for these patients are opioid agonists. For the longest time, since the 1970s, methadone has been the big one, and it's probably the one that you've heard the most about. So the combination of methadone and counseling and behavioral therapy has been the standard for heroin addiction during pregnancy. For modern opioid use disorder, we've now seen buprenorphine being used more often. I'm going to talk about sort of the benefits and the downsides of both of those against each other's. But having these opioid agonists on board is really going to help your patient prevent withdrawal symptoms and reduce the risks of relapse. And neonatal abstinence syndrome is going to be expected when these patients are on these medications, but it's treatable and it's a little bit more predictable than if these patients were on street drugs. So quickly about methadone. This one is strictly an opioid agonist, and you have to go through a comprehensive treatment center in order to get these medications. This usually involves addiction counseling, family therapy, nutritional education, and these providers who are prescribing methadone to these patients are going to be in constant communication with the obstetrics team, because as these patients go through their pregnancy, their dosing will probably change throughout their pregnancy. And keeping that open loop of communication is really going to make sure that their medication is being titrated to the right effect so that they're not going to have withdrawal symptoms, reduce the risk of relapsing. The one thing you're going to want to keep in mind is that methadone does have interactions with other drugs, so like antiviral medications. So if your patient has HIV, you just want to make sure that there's not significant interactions that could prolong QTC and lead to like cardiac dysfunction. Buprenorphine, on the other hand, this is a partial agonist, making overdose much less likely, and it's a lot more available for patients. So instead of going to a treatment facility, they can get this medication in an outpatient setting. There's less need for dosage adjustments throughout their pregnancy as well, and typically you'll see a less severe version of neonatal abstinence syndrome. Although all of that sounds pretty good, some of the disadvantages compared to methadone are there's some rare reports of liver dysfunction. There's also a lack of long-term data on infants and child effects, since this is sort of becoming a new thing in pregnancy. There's also potentially more risk for precipitated withdrawal, since it's not as strong of an agonist compared to methadone. And because you're not getting it from a treatment facility, there's a little bit more of a risk for diversion because there's not as much oversight. Now, if your patient's already taking methadone, it's not recommended to switch to buprenorphine because of that risk of withdrawal, with it being a little bit more of a partial agonist compared to methadone. So intrapartum care, patients who are on these opioid agonists are going to require a higher rate or higher dose of opioids to achieve adequate analgesia. And that's because they've just built up tolerance. So the more anyone is exposed to opioids, we know that they develop tolerance, and they just need higher and higher doses to saturate their receptors and get to that analgesic level. Injectable NSAIDs like ketorolac or Toradol are highly effective in this patient population, since that's a different receptor. And this really falls into sort of our multimodal approach to treating pain. And then you want to maintain their daily doses of the methadone or buprenorphine so that you don't fall behind in terms of their body's demand for the opioid agonist. The other things for multimodal are going to be like your neuroaxial analgesia, so like epidurals, and then on top of the Toradol, Tylenol is also a great option. And then lastly, postpartum care. Breastfeeding has actually been shown to be beneficial for patients who are on methadone and buprenorphine, decreases the severity of neonatal abstinence syndrome symptoms. There's less need for pharmacotherapy for those infants, and there's shorter hospital stays. The American Academy for Pediatrics actually recommends breastfeeding regardless of the dose because this transfer of medication is so minimal to the baby. The one place where they want you to have some hesitation or put the brakes on is if your patient is taking codeine and tramadol, and that's because infants or children really of any age have varying degrees of metabolism of those drugs, and so they can build up toxic levels of sort of broken down parts of that medication, which could lead to overdoses. Continuing opioid agonists in the postpartum time is very important. This is when your patient is going to have the most amount of pain, obviously. And if we're not keeping up with that pain control, this is when patients are going to relapse and then go back to whatever drugs they were using before to get themselves feeling better. Lastly, you're going to want to counsel them on contraceptions because unintended pregnancy rates for people or patients who have substance use disorder is around 80%. So making sure that they're having the appropriate family planning and aren't put into more stressful situations that's going to drive them to seek out drugs or relapse would be obviously very beneficial for these patients going forward. And these are some of my references. And that is my talk.
Thank you so much, Dr. John. That was a great overview. You blasted through it, but I think that it's a really great brief understanding for people who are participating in our QI program. I will put Dr. John's email in the chat, and then if people have questions, feel free to chat them in. And if we have time at the end, Dr. John, you can answer them then. But again, thank you. So now we're going to move on to Dr. Stefka Fabbri's presentation. Dr. Fabbri is going to talk about Denver Health's QI project in relation to decreasing opioid prescribing. So Dr. Stefka Fabbri is a full scope OBGYN at Denver Health Medical Center in Denver. Dr. Fabbri serves as the medical director of labor and delivery, the Department of OBGYN Director of Patient Safety and Quality Improvement, and the Associate Director of Inpatient OBGYN. So we're super excited to have Dr. Fabbri here to present on their quality improvement project.
Great. Thank you, Elena. You guys, sometimes my mic goes off, so please let me know if you do not hear me well. We'll try to adjust. And Dr. John, thank you. That was a great overview. And, you know, a couple of historical, I guess, perspectives. Or when I was in medical school, pain and excessive pain became the 5th vital sign. And I think, you know, expecting our patients to have no pain and providers and medical staff being monitored on how much pain their patients are in was one of those, I think, things that had unintended consequences down the line. But also, when I was a resident, we routinely prescribed 30 to 40 Narcans or oxycodones to patients after C-sections. So it was, now it's really mind-blowing knowing, you know, having all of this data. So thank you. And Elena, do you need me to share the slides or you got them?
I have them. I will present them for you.
Perfect. Thank you. So thank you for that overview. It's really great. And, you know, my presentation has to do with a QI project that we started and instituted at Denver Health. And it really is a kind of a pragmatic approach to all of these recommendations that you reviewed. So we basically, you know, we knew that we're over prescribing, but we weren't quite sure by how much or really how to go about it. So we decided to, you know, focus on how can we decrease opioid prescriptions at time of discharge after C-sections. Fortunately, you know, we stopped prescribing or routinely prescribing opioids after vaginal delivery a while back. But there's certainly some variation among providers on the postpartum floor for C-section. So next slide, please. So this was actually a resident kind of QI project. You know, I'm lucky to work with students and residents who are also interested in quality improvement. Next slide, please. And this is currently being kind of in the process of being published. I think Dr. John did a great overview of, you know, what the problem is. So just again to review some of these, but 44%, there's 44% risk of long-term use or misuse, even after a single prescription. And I think that puts things into perspective, knowing that C-sections and, as you mentioned, hysterectomies are some of the most common procedures in the US. So we need to take action. OBGYNs are in the perfect position to do so. And Dr. John did mention about the risks of overprescribing and the misuse of leftover tablets. And as we know from the Colorado CDPHE data and maternal morbidity reviews, opioid drug misuse is one of the primary drivers of maternal morbidity and mortality in our state. Huge problem. Next slide, please. So what did we decide to do? I asked one of our active interns, or what used to be called a sub-I, to review, well, how many opioids do our providers prescribe? And how many opioids do patients use? And as you can see, the first graph here has to do with the average number of 5 milligram oxycodone tabs by post-op day. Most patients use 0 on post-op day 0, and that makes sense because they still have their spinal. By post-op day 1, the average use was about a little over a pill, and by post-op day 2 was a little under a pill. And how did that correlate with what is it that we prescribe? And here on the y-axis, we have how many tablets of 5 milligram oxys was the patient sent home, versus on the x-axis, how many tablets did the patient use while in-house. And as you can see, we were all over the place. A bunch of patients used 0 oxy tablets at home, but they were discharged home or while in-house, but they were discharged home with up to 15 tablets, right? So same with using, 2 tablets, and then patients were discharged with anywhere between 0 or 20 tablets home. So we were all over the place. And we also found that about 58% of postpartum patients who did not require any inpatient opioids after their C-section were still discharged home with opioids. Next slide, please. So huge discrepancy. So what we decided? We did some research. We found other similar studies that had been done, and we came up with this postpartum opioid prescription guideline, where we asked our providers to actually review how many oxys was the patient using on their last day prior to discharge, and based on that information, send them home with the appropriate number of oxy tabs. So if the patient used 1 or less, they were sent home with 0 tablets. If the patient used between 2 and 5, they were sent home with 4, and so forth. Now, I have to mention here a couple of things. One, we do have a while back, 4 or so years ago, 5 years ago, we did adopted expedited review after surgery or ERAS for short, into our postoperative recovery, both for GYN and OB patients. And as part of this clinical guideline, we have adopted, I would say quite vigorously, multimodal pain control. So our post-op patients do get, for the first 24 hours, scheduled Toradol or ketorolac. If there's no contraindication, scheduled Tylenol, which is then followed by scheduled ibuprofen and scheduled Tylenol, plus lidocaine patches for incisional pain. So we do kind of try to rely on other modalities before the patient needing to use opioids. The other thing that is important for these data here is that we did exclude patients with opioid use disorder or those who had significant postpartum complications, just so we can see what we can do for the majority of patients who have routine C-sections. So we asked providers to follow this scheme, and they did quite well. We have a really a group of providers who are really dedicated and compliant. And then what the group of researchers did was to conduct postpartum phone surveys at 14 and 42 days to inquire about how was the patient's pain, how would they rate their pain, how many tabs did they use, how many unused tabs did they have, were they satisfied with their pain control, and so forth. And we actually used a tool that had been validated in prior studies, so we didn't just come up with those questions. Next slide, please. And what we found out was really great. I mean, we had great results. So there was a substantial decrease, and just for standardization purposes here, we use morphine milliequivalents, which I think, Dr. Klie, correct me if I'm wrong, but I think one 5 milligram oxytab is about 7.5 morphine milliequivalents. So we went from about 53 at time of discharge to 18, and that decrease was significant. Then the number of patients who were discharged home with no oxys or 0 milliequivalents went from about 40% up to 60%, and that too was significant. And it's not shown in this chart, in this table, but in terms of unused pills, which, as Dr. John pointed, is a major problem with associated risks of misuse and diversion. Before we did this study, before kind of instituting this scaled prescription, about 30% of our patients had no leftover pills. After this study, about 71% of patients had 0 pills left over, which too was significant. Also, the amount of pills that people had left over decreased from, on average, 9 leftover pills before our project down to 3 after we instituted this scale. So overall, great adjustment in our prescription practices. And then, of course, we looked at some potential unintended consequences. So, for example, well, did patients need additional prescriptions afterwards? So, and turned out that wasn't necessarily the case. In the post-intervention cohort group, there were only 2, and one of those prescriptions was actually not filled. And then we also looked at unscheduled or emergency room visits, and those 2 did not go up. And then one can then argue, well, how did people do with their pain postpartum? And next slide, please. And here are some of the results of the survey, the phone survey that we did at 2 and 6 weeks postpartum. And turns out that overall, people reported about the same. So how was one's pain controlled at home? Those who reported poor and moderate control was about the same between the pre and post-intervention group. Next slide, please. We also, asked, was your pain what you expected? And again, overall, how people responded did not change based on this prescription practices. Next slide, please. I'm not sure if there's another one, but
That's all of them.
that's all. Okay, great. Yeah, well, it's there's more data to this project, but I think the main point being that it is doable. And for those who know me, I'm a big advocate of using our electronic medical record to help providers make decisions and to facilitate things. And one of the things that we're currently working on is actually when we're discharging patient and writing for an opioid prescription, it would be really great if if Epic can tell us how many tabs did that patient use, so that way the provider doesn't have to go back and review the record, so it's a time saving. But anyway, it can be done safely and not at the expense of the patient's experience. So,
Great.
Thank
Thank
you.
you so much, Dr. Fabbri. That was a great overview of your quality improvement project. If anyone has any questions for Dr. Fabbri, you're welcome to put them in the chat. And then we'll also be sharing her slides after as well. So our last presentation is going to be by Dr. Kaylin Klie. Dr. Kaylin Klie is an attending physician at both Denver Health and the University of Colorado Hospital, focusing on family and addiction medicine. Additionally, Dr. Klie serves as the program director for the Addiction Medicine Fellowship at the University of Colorado School of Medicine. And today, Dr. Klie will be discussing stigma and bias in regards to perinatal substance use, as well as best practices to assess risk in the perinatal population.
Yeah, hi guys. Thank you so much. Thank you, Dr. Kenny. Thank you, Dr. Fabbri. I usually get to talk more about substance use disorder because that is my passion, but I actually have quite a bit of interest in pain and take care of at a different clinic, not our OB clinic, a significant number of folks who I think of as our opioid orphans, right? So all these folks who got started on opioids during the pain is the fifth vital sign. I definitely remember some very nice lunches catered by Purdue Pharma during training. And then in 2016, when the CDC released their first opioid prescribing guidelines, kind of in response to overprescribing, there were a lot of people who got cut off of their medication quickly, either quickly or suddenly, like no more medicine. And those folks really struggle, right? There are a number of people who do have more benefit than risk from opioids, but that is a smaller number than we thought, right? And so the vast majority of people, and especially for this population of folks after C-section, we're usually going to be in that more risk than benefit for long-term prescribing of opioids. But that's not what we're necessarily talking about today. Okay, so we're going to talk a little bit. I'm going off script, Elena, a little bit. I really want to introduce something that I think people don't get introduced to very often, which is actually not as much around screening. I'm happy to talk about screening for substance use disorder, which is maybe like a whole separate talk. Denver Health has done a really nice job implementing universal screening, and what universal screening for substance use disorder means is using a validated verbal or electronic or paper and pencil tool, right? A questionnaire that gives us information about a person's relationship with substances, different substances. It's not a urine test. It's not a those are not screening modalities, right? Screening means asking people about their history of substance use using a validated tool. What I want to introduce is something that people are maybe less familiar with, which is the tools that are available specifically not to diagnose a substance use disorder, but to gauge before prescribing an opioid, the risk to that individual person potentially for continuing to have opioid requirements and or developing symptoms of opioid use disorder. And then also validated screening tools for people who are already receiving opioids for chronic pain, or maybe these are folks showing up to you for a postpartum follow-up who've been taking opioids now consistently after their C-section for 2-3 months. Being able to evaluate folks who are already taking prescribed opioids for pain for risk of misuse and progression to opioid use disorder. And then I get to skip over one thing that Dr. John already talked about, which is the shared decision-making tool, but I'm happy to talk a little bit about kind of how we can apply that specifically to people who already have a substance use disorder and kind of the, the nuances and discussion around providing opioids to people who've worked really hard to be sober from opioids, for example. Okay. So you can just kind of think back if these have a place in your practice already, you get a gold star, but these are usually not well implemented. These are screening tools that have been developed to have a patient respond to before prescribing, opioid naive, right? So these are tools for people who are opioid naive, they're not already prescribed opioids, to help determine kind of what the risk might be for that person. This is an example of one, the opioid risk tool, or the ORT. And you can just kind of take a look. Some of the things are not a surprise, right? But if people have a family history of substance use, a personal history of substance use, including alcohol, including other substances, specifically validated from female at birth people is a history of pre-adolescent sexual abuse, is highly correlated with misuse and progression to opioid use disorder after initial prescription of opioid medication for pain. And then also differing risk based on different mental health conditions. And then what you do, you can see a score of 8 or higher indicates a high risk. A score of 3 or 0 on the ORT is a lower risk, but there's no score that's a no risk, right? So even with our best efforts at thinking about, thinking carefully ahead of time, what is the risk to this individual person for prescribing opioids? None of us are a 0 risk, even without any of these indicators. These are tools that are used. I like these kind of just like broken out by different type, right? So there's different ones that are for before prescribing opioids for opioid naive people, for the opioid experienced people who are already taking prescription opioid medication, and then self-report versus provider reported, right? So you can see that there's different tools filled out by different people. And then here I'm gonna see if I can, I might have made this difficult for myself, but what I wanna show you is this actually on MD Calc. So this is the, and the reason I chose this one to show is because I think it's very good, but it's also the one that's most likely to be built into your electronic medical record. This is built into the Denver Health Epic system. And so if you use Epic, this COM, the current opioid misuse measure, exists within Epic. If it's not live in your institution, you would just need to ask Epic to activate it for you. But let me see what happens if I end show, because I think I pulled this up already. Let me see. Oh, now I see I was clicking on everything trying to find a couple of things I want to share with you. But here's what it looks like. Okay, so this is on MD Calc, and you could fill this out like with a person in the room. You can just pull it up if it doesn't exist within your EMR. And these are the types of questions that have been validated to predict people who will are currently misusing their prescription opioid or maybe developing an opioid use disorder. And so you can see how often have you had trouble with thinking clearly or had memory problems, right? Looking for side effects related to opioid toxicity. How often do people complain that you are not completing tasks? How often have you had someone other than your prescribing physician to get had to go to someone else to get more meds besides your prescription? Have you taken your medicines differently than prescribed? I think that's one that comes to mind, right? When we're thinking about trying to assess. How often have you seriously thought about hurting yourself? How much time was spent with thinking about opioid medications? How often have you been in an argument, right? This is how often have you had trouble controlling your anger? This is getting at symptoms both of opioid toxicity, right? Many people become irritable under the influence of opioids, and symptoms of opioid withdrawal. Many people are more irritable when they're having interdose withdrawal. And so you can see that these are some just really interesting questions that might be a little bit different than how we would think about asking. Like if I just was going to ask a person, are you misusing your prescription medication? I might not have thought to think of these kind of more nuanced questions. And so I like to just show what that looks like for people's reference. And then you can go online and take a look at it and see what you think. Put it back in this mode. This is a really interesting study. It's a little older now, and now with all the good efforts at reducing opioid prescribing after C-section, hopefully this number is lower. But this was published by Dr. Bateman and his team in 2016. He's actually an obstetric anesthesiologist who has done some incredible work in this field. And what he found was that out of approximately 1.3 million C-sections done in the years prior to this study, 1 in 300 opioid naive, so these are people who had never been prescribed an opioid before their C-section, who received a prescription for opioids after their C-section, were still taking opioids 1 year later. And that doesn't sound like a large percent. It's not 1 in 300, right? But when you think of the volume of C-sections, which may be less after you complete this bundle, that still comes out to about over 4,000 people, 4,333 people who came into having their C-section not having any opioid use history. And 1 year later, we're still taking opioids. So it's not an insubstantial number of people who may be affected and go on to develop chronic opioid use every year, right? So that's each year. And again, they found that things that correlated with continued opioid use after your C-section were history of substance use, personal history of substance use, highly correlated with a history of tobacco use, and then a history of a back pain diagnosis, a history of a migraine disorder diagnosis, and history of treatment with an antidepressant or a benzodiazepine within 1 year prior to that pregnancy. And so these were the characteristics that were associated with ongoing opioid use. Interestingly, what was not associated with persistent use was the number of the type of opioid prescribed, whether it was oxycodone versus hydrocodone or other. The MME prescribed was not associated with persistent use, and the number of days, or the number of tablets, right? The number of days of medication prescribed at discharge. And so I share this not only to highlight the good efforts that we are making to reduce the amount of opioids that are getting out into our community and going unused anyway, but also to help broaden our thinking about doing what we can at a system level to reduce overprescribing of opioids, and then taking it a step farther to think about that individual person and how our system practices may still not serve that individual person if they have some of these significant risk factors. Now, what I want to say very, very clearly is that people with a history of tobacco use, people with a history of migraine, people with my patients with history of opioid use disorder, no one's ever been no one's see the light moment is having pain medication withheld from them during an acute pain episode, right? So none of my patients ever tell me that the time they got ready to seek treatment and recovery was when their pain was undertreated. No, I'm not saying we should withhold medication from people during acute pain episodes, but I do think that we should have this type of information available in our own minds to share with our patients when we're thinking about kind of specific recommendations for them. And that's where reiterating what Dr. John shared already about this shared decision-making intervention. I'm going to shift gears for a second and talk about something that's increasingly important to think about, and that's about fentanyl. So Dr. John demonstrated kind of we're in the third wave. This is called the third wave of the opioid epidemic, where we had prescription opioids leading the charge, and then heroin, and now we're into fentanyl, right? Fentanyl has almost completely replaced heroin and prescription tablets that as the predominant opioid that's available for non-prescription use. This is not, illicit substances are not driven by consumer preference. So it wasn't that a bunch of people who use opioids illicitly got together and said, I think we should request fentanyl. This isn't a drug of choice. People who use substances non-prescribed do not have a choice about which substance to use. They are at the mercy of what is produced and what is available. And the reason that fentanyl has taken over is because it's incredibly cheap. It can be manufactured in a lab. You don't need fields of poppy plants to try to hide to produce heroin. You just need a small lab and basic chemicals. And it's very potent. And so for a small operation, you don't have to produce very much, which is much easier to transport. And it's very cost effective, right? So it's very potent. You don't need to produce as much to be able to sell quite a bit. And mostly in Denver and the surrounding Denver metro area, fentanyl will come as a powder or as a pressed pill. The reason this has become a huge deal is that even several years ago, when my patients who had a history of substance use disorder were having umbilical cords tested at time of birth for substances, it never even crossed our mind, if there was trace fentanyl in the umbilical cord, that person was misusing fentanyl. it was like, oh, of course, this is from your epidural, or this is from getting IV fentanyl during labor. Now that fentanyl is the main substance for which people are seeking treatment, and the main substance being misused by people who have opioid use disorder, having fentanyl toxicology positive either in your own urine, the infant's urine, or the infant umbilical cord at time of birth can be the difference between a report to Child Protective Services or not. And this is super traumatizing for people who have been sober through their pregnancy or gotten sober through their pregnancy, and then they're told their baby tested positive for fentanyl when the administration of the fentanyl was through anesthesia, right, and analgesia. So I really think this is kind of like a leading edge question for us to think about. Like, should we be offering, I mean, I talk with my patients ahead of time about what to expect when they come into the hospital as far as pain options. Many of my patients say, by no way, shape, or form do I want IV fentanyl, but they don't know that the IV medication option is fentanyl. They just think it's IV pain medicine of some kind. And then many of my patients have no idea that there's fentanyl in epidurals. And so having those conversations ahead of time, ideally in the prenatal setting, but definitely on admission, if you're taking care of somebody with opioid use disorder, I think we really now have kind of an ethical requirement, an imperative to be explicit about the possibility of fentanyl exposure with our traditional medications for controlling pain during childbirth. And so just keeping that in mind. I've had several patients recently who requested to provide a urine toxicology on admission so that they could show if something tests positive for fentanyl, it was given during labor. And here's my urine before I have any pain medication, and then any testing that's conducted after I've had an epidural. Hopefully that helps make very clear that the fentanyl was from the epidural or from IV pain medication, not from illicit use. Okay. The number of there's a few different studies. It's really interesting to read. The number of infant umbilical cords and infant urines that test positive for fentanyl seems to be correlated to how long that person has fentanyl exposure. So pretty much how long they have an epidural in place. And so kind of thinking about that component too can be really important for us as far as like not withholding, but just letting people know that there's a higher chance that they could have positive toxicology with a longer epidural versus if they want to walk around for another couple hours, that's totally fine. Okay. And then introducing an idea. How are we doing on time? Oh, we're totally out of time. This is an idea that I think is worth us considering, is that not every person who has significant feelings about prescription opioids has opioid use disorder. And so this is this phenomena called complex persistent opioid dependence. It's people who are in that gray zone where they started taking opioids for chronic pain, and they have developed some kind of definitely physical and also kind of psychological dependence upon this class of medication, that when we try to taper or take away those opioids, because we see the data that they're not really very evidence-based for chronic pain, people really don't do as well, right? They have decreased function, they become clinically and sometimes psychiatrically unstable. And so I really recommend these two papers, especially this 2020 review by Dr. Manhapra that just really describes eloquently the folks that we see in this gray zone and how we can have the language to describe their experience as distinct from opioid use disorder. I'm going to skip through this. Here's some words that I want us to know. And here's some words that I think we can just kind of like push the eject button of our lexicon, right? People who are asking for pain medication who have an opioid use disorder, it is much faster to get opioids outside the hospital than it is inside the hospital. And so if people wanted to use opioids, they would not be asking us. They would be going to get opioids on their own. People who are asking for opioids to treat their pain are not necessarily drug seeking, right? They're pain relief seeking, but that becomes very biased, I think, when people have a history of substance use disorder. And with that, I will say thank you.
Thank you so much, Kaylin. I will just run through some housekeeping stuff really quickly. Definitely if people have questions and can stay on. Feel free to use the chat. And then once I'm done with housekeeping, you can take the stage and talk as much as you want. So I'll put some things in the chat. The link I just put in the chat for the evaluation, everyone please fill it out, but it's also if you would like to get nursing or social work CE, that evaluation is how you'll get that nursing or social work CE. And then just one other, a couple other things. I will point you to, we have a couple of upcoming events that you might be interested in. I'll put those in the chat as well, and then just share my screen really quickly so you know what I'm talking about. If I can find the screen that I want, which I can't. Okay, hold on. Oh, okay. Okay, these are the upcoming events that I just put in the chat. This is just a more aesthetically pleasing version of what I put in the chat. This is the link to the CE, which is that link I put in the chat that's like to the evaluation. It's like forms dot something. That is both the evaluation that we would love for everyone to fill out. And then if you're specifically requesting CE for social workers or nursing, you have to fill it out. So please fill that evaluation out for us, whether or not you want CE. And then that's all. You can contact us anytime, info@cpcqc.org for questions, and we will direct your questions to the right person from there. And we'll be sending out these slides. Kaylin, if there's anything you want us to send out, just email Elena and we can get whatever other resources. Same for Stefka and Dr. John. Any additional resources you'd like us to email out, we will email out. And yeah, thank you all for your time, and I can keep the Zoom up for a couple of minutes. So if anyone has questions or needs those links.
Thanks, guys. I just saw the message that my screen didn't change when I was trying to show you the question. So I put the website link in the chat. And there's also a hyperlink in my slides, which Elena, you absolutely can share.
Perfect.
Thanks all.
Yeah, thank you.
See you later.
Yeah. Thank you also to Stefka and Dr. John. I'm sure Elena will send follow-ups. She had to run to present at something else. So I am her less worthy substitute that knows less about what's going on with all these links.
Thanks for having me. This was a blast.
Yeah, this is great. I love this topic.
Great
Great.
discussion.
Thanks, guys.
Thanks, Stefka. Okay, well, I will close the Zoom and then you all will receive all the follow-up information again via email from Elena, which will include the slides and all of the links and anything else you might need. So thanks so much for attending, and we'll see you all soon.